بسم الله الرحمن الرحيم. أنا بتشرف بوجودي مع حضراتكم النهارده دكتور محمود المتيني، رئيس جامعة عين شمس، وأنا الدينامو بتاع جراحات زراعة الأعضاء، وإن شاء الله يبقى عندنا حسن ظنه. إحنا إن شاء الله فاضل لنا حاجات بسيطة إن شاء الله هنعرض على حضراتكم البرزنتيشن. و احنا كنا عملنا كونتاكت مع الماسترز اوف ليفنج دونر لانج ترانسبلانت اللي هم من كيوتو، على راسهم البروفيسور هيروشيدا تي. هو الحقيقه one of the leading surgeons في المجال دوت، وهو الحمد لله يعني كان فاضي وهيخش معنا النهارده من كيوتو. Dear sir, you hear me?
Yes.
Okay. Thank you very much for joining us today. It's been a long time since we met, and hope the COVID era will get us back to Kyoto for just a nice refreshment for the living donor lung transplant. Please go ahead with Professor Dati.
Thank you very much, kind invitation. It's my great pleasure to give a talk on living donor Lobo lung transplantation. And I also would like to congratulate Ain Shams Center for the renovation. I have nothing to disclose in my talk. Living donor Lobo lung transplantation was developed by the group of University Southern California in the early 1990s to deal with the donor shortage in the United States. In this procedure, two healthy donors donate their right or left lower lobes, and these two lobes are implanted to the recipient as a whole right and left lung. Because only two lobes are implanted, this procedure was applied to small children with cystic fibrosis in the beginning, but we now know that this procedure can be applied to adult patients as well if the size matching is acceptable. They reported on the result of 123 patients receiving this operation. The 5-year survival rate was 45%, which was similar to the report on cadaveric lung transplantation. Stimulated by their pioneering work, we began our program of living donor Lobo lung transplantation in Okayama University. The first patient was a 24-year-old female with a bronchiectasis associated with primary ciliary dyskinesia. She was on a ventilator for 2 weeks, at which time she received a robe from her sister and from her mother. This is the movie of this operation, which was performed 23 years ago. The right lower lobe was extracted from her sister, and the left lower lobe was extracted from her mother. This is the recipient operation. The clamshell incision was made, and as was expected, there was a tight adhesion in the pleural cavity, which was taken down by cautery. The right lung, which was filled with pus, was extracted, and the left lung was also extracted. The right lower lobe from her sister was placed in the chest cavity. You can see how small it was. This is the anastomosis of the pulmonary artery. After the lung was reperfused and reventilated, the left lung was placed, and which was implanted and reperfused in the same manner as for the right side. PaO2 was over 500, and the patient came off the bypass quite easily. This picture was taken immediately after this operation. The center is myself. And she is now 23 years after this operation. She's still doing very, very well. The right side is her chest cavity, chest x-ray. The right side is her sister's right lower lobe, and the left side is her mother's left lower lobe, but the chest x-ray looks like the normal chest x-ray. Inclusion criteria for living donor lobar lung transplant recipient is as follows. The age should be less than 65. The patients should meet the conventional criteria for cadaveric lung transplantation. We accept only critically ill patients who are unlikely to survive the long wait for cadaveric lungs, which is the average waiting time currently in Japan is over 800 days. Regarding the inclusion criteria for living donor, we accept only relatives within the 3rd degree or spouse, so we do not accept volunteers or strangers. The age should be between 20 and 60. ABO compatibility is required at this moment. Good blood gas and good pulmonary function are mandatory. How to inform this operation to the potential donors is very, very important. We inform them about permanent loss of vital capacity in about 15%. We inform them about the possible various complications and possible mortality as well. To avoid coercion, we ask an observer to be present. We do an individual interview so that the potential donors can express their thoughts honestly. And also we repeat this interview at least 3 times to give them what is called cooling off period. This slide shows the activity of lung transplantation in Japan. It has grown significantly over the last 20 years. In 2010, we revised the law and the number of cadaveric lung transplantation from brain dead donor has increased by 5 times. But still, you can see a significant number of patients required a living donor lobar lung transplantation. This is because of the significant rise in waiting lists over the last 20 years. And only a small portion of the patient could receive a conventional cadaveric lung transplantation. As a result, the mortality rate on the list without receiving lung transplantation exceeds 40%. It is for this reason that living donor lobar lung transplantation is still a valuable and requiring option in Japan. There are 10 lung transplant centers in Japan. I used to be in be working Okayama University, and 14 years ago, I moved to Kyoto University. Kyoto University has done the largest experience of lung transplantation in Japan, followed by Okayama University, Tohoku, and Tokyo University. In my personal experience over the last 20 years, has reached over 300, and as you can see, nearly half of them were from living donors. This is because the sicker patients are sent to me. They are very sick preoperatively. 60% were bedbound and 14 were on a ventilator, and 2 patients were on ECMO at the time of living donor lobar lung transplantation. They came from all over the country to receive this operation because they are quite sick. We often go to see the patient in a local hospital and evaluate. If the patient is a candidate, then we bring the patient sometimes with an emergency, in an emergency situation. using a flying ICU as shown in this slide. This operation requires 3 independent teams at the time of living donor lobar lung transplantation. So this is a manpower requiring operation. I usually scrub in a recipient team. So it is important not to hurry up the donor team. And even if I see this kind of vascular cutting edge, I never criticize the donor team because the priority exists in donor safety. We have accepted various indications for living donor lobar lung transplantation. Interstitial pneumonia and bronchiolitis obliterans and pulmonary hypertension are the 3 major indications. Only 2 lobes are implanted in this operation. Size matching is a very important issue. So we have used 2 ways of size matching. The first one is a functional size matching, which is used to evaluate the undersized graft. The estimated forced vital capacity should be greater than 45%. The second one is anatomical size matching, which is depending on a CT volumetry, and which is used for assessing a oversized graft. We now know that the graft greater than 200% can squeezed into the small chest cavity. We have developed several strategies for example, undersized graft. The first one is upper lobe preserving transplantation, which we have done already on 14 patients. For example, this was a young boy with a pulmonary hypertension. The left side is preoperative chest X-ray, and the right side is bilateral upper lobe preserving living donor lobar lung transplantation. The pulmonary artery pressure was normalized, and you can see the significant reduction of cardiac size. Perfusion scan after this operation showed a majority of blood flow were directed to the lower lobes, which were implanted, indicating that the spared upper lobes functioned as a reservoir immediately after transplantation, thus to avoid lung edema. And also upper lobes provided adequate chest cavity for the small lobes implanted. Another strategy was right to left inverted living donor lobar lung transplantation. This is because the right lower lobe is a little bit bigger than the left lower lobe. For example, the recipient was significant severe idiopathic pulmonary fibrosis, and after a inverted living donor lobar lung transplantation. The right side is right lower lobe implanted, and the left side is the right lower lobe, which was inverted and implanted into the left chest cavity. Strategy for oversized graft is, for example, a single lobe transplantation for small children. This was a 60-year-old boy, very small kids, and the graft size, which was from her mother, was 270% bigger. And the patient was on a ventilator, very, very sick, and we did an urgent right single lobe transplantation. The lobe from his mother expanded beyond the midline, and the left lobe, left lung, which was fibrotic, was very small, and the heart was shifted toward the left. This young boy could walk like this only 1 month after receiving this operation. The another strategy is the segmental transplantation. This was a young boy receiving lobes from his mother, his parents, but his father's right lower lobe was too big. So we did a segmental, upper segmental resection on the back cable. Pulmonary artery and bronchus were divided, and the pulmonary vein was ligated and then divided. Finally, intersegmental plane was developed by a linear stapling device. The bronchus was trimmed, pulmonary artery was trimmed, and pulmonary vein was trimmed. And then this basal segment was placed in the chest cavity. This is the bronchial anastomosis. This is the venous anastomosis. This is the pulmonary artery anastomosis in an end-to-end fashion. This is the conclusion of this operation. The X-ray looks very good. The right side is right basal segment implanted. The left side is the left lower lobe implanted. We have recently performed very complicated segmental transplantation as shown in this figure. This is after this operation. The left lung is the right segmental 6, which was inverted and then implanted as the left graft. We recently performed a living donor lobar lung transplantation for lung injury after COVID-19 infection. The patient was an adult female and was on VV ECMO for longer than 3 months. And her son and her husband donated their lobes. The patient was on ECMO, as shown in this slide, but was clear in consciousness and could do some rehabilitation, as shown in this movie. Before the X-ray showed a completely opacified lung before transplant, and after this operation, she did very well, and she has returned to her normal life now. This is the long-term result in my personal experience in 133 patients. The 5-year survival rate was 83%, 75% at 10 years, and 67% at 15 years, which was much better than the world average. Especially the children's result was excellent. The 10-year survival rate was more than 80%. Because 2 different lobes are implanted into the recipient, the immunologically it sounds complicated, but it was not. For example, this young girl received lobes from her parents and became a cheerleader. But this picture was taken 1 year after she developed the chronic allograft dysfunction. Washout phase of ventilation scan showed a marked air trapping only on the right side because of the functioning contralateral lung. She could maintain a good quality of life even after a chronic allograft dysfunction development. The outcome of a living donor is very important. Their pulmonary function never recovers to the baseline, but we have not encountered any operation-related death. Finally, I would like to emphasize the importance of team efforts of this operation. This is our result again, and this is the result of living donor lobar lung transplantation performed at other institution in Japan. This is the result of USC, which I have shown you in the beginning of my talk. And this is the result of St. Louis University, and this is the result from Brazil. So the result after living donor transplant differs among transplant centers, so it is very important to stick to a strict protocols to have good results. I would like to thank the organizers for kind invitation. Thank you.
Thank you very much, Professor Datei, for your impressive talk. Can you please, I have a question if you allow me.
Sure.
Can you give us just more information about the first living donor lung transplant in a positive COVID patient? Did you have any protocol regarding the vaccination, regarding the probability of reinfection after transplantation? How did you manage this?
Thank you very much. We did not have any protocol because this was the first case. So at which time, when we had a referral for this patient for possible living donor lobar lung transplantation, we searched literature and we learned information from the Medline, and also we got a most updated information from Vienna University. They have already done 10 cases at that time from the cadaveric donors. So we learned regarding the infection and so on. The patient had a COVID-19 infection 4 months ago, and she had a repeated PCR test which was negative already. So we did not have any protection during the operation, and she did not develop any recurrent COVID-19 infection.
Okay, thank you. We just a final talk. Final comment. We would like to hear from you frequently, and it will be our pleasure to welcome you soon in Cairo.
Thank you.
Thank you very much.
After this very nice lecture, we enjoyed it a lot. I have the pleasure to present Dr. Ahmed Mustafa. He will talk about lung transplant, soon to be introduced in Ain Shams University.
Please allow me to introduce to you the living donor lung transplant. We have been working on this project since December 2018, and this is a brief presentation or lecture on our preparation for this project. I've been trained in France, HEGP, Hôpital Européen Georges Pompidou. They performed cadaveric lung transplant. It was a very great experience. And from that moment, I had a passion to introduce this kind of surgery, maybe in Egypt one day. Here we have, we were in the helicopter and just touring around Tour Eiffel. So Ain Shams University hospitals can serve a huge number of patients. This information are for the lectures for the audience, the non-Egyptian audience. The number of patients can get to 1 million per year, 150,000 inpatients with 4,000 beds. We are upgrading existing hospitals, adding new ones, opening new subspecialties, and modernizing the services and reforming a lot of administrative work. I here can congratulate the liver transplant team for the 20 years of experience, and they have carried more than 1,500 operations, and we are all proud of this. For us, the thoracic surgery department in Ain Shams University, all surgeons had their initial training abroad. We had a European experience by far. It's an established adult and pediatric referral center for complex airway, redo, oncology, trauma, and vet surgery. We have a valuable transplantation experience in King Faisal Specialized Hospital in Riyadh, Kingdom, Saudi Arabia, HGP, and lastly Kyoto in Japan. Last year, we have operated like 425 cases, between 256 open surgeries, 160 vets, and 650 bronchoscopies. For a population over 100 million without lung transplantation services for terminally ill patients with respiratory failure, it's a little bit awkward. Unfortunately, our nation had built the pyramids, which were actually tombs, and used the mummification in the past to preserve the dead. Now accordingly, we are facing a little bit of resistance to apply the cadaveric organ donation. So we don't have another chance except to start the living donor lung transplant. The living donor lung transplantation just emerged, and all literature came from Japan due to the prolonged waiting time for the cadaveric lung transplantation, as Professor Dati stated. They had encouraging results showing that bilateral living donor Lobo lung transplant provides equal or better survival than the conventional cadaveric. I won't go for the recipient selection. Professor Dati has covered this point. And a brief on the surgical technique, I can get a quote from Professor Dati's publication in the Journal of Thoracic Disease 2017. It consumes a lot of manpower, it requires a lot of manpower, 3 surgical teams and a back table team. They communicate with each other very closely to identify the appropriate timing for graft extraction and to minimize the graft ischemic time. The recipient and the right donor come together at the operating room together, and after 30 minutes, the left-sided donor come later. Briefly through the donor lobectomy, it's not a traditional lobectomy. We just do a posterolateral thoracotomy at the 5th intercostal space. We dissect the fissures. We open the pericardium near the inferior pulmonary vein circumferentially. It's very important to preoperatively identify the anatomy of the pulmonary artery branches on the right side or on the left side. When the recipient in the other room has his nominectomy or is nearly completed, we give the prostaglandin E1 IV. Then, before applying the clamps, we give the 5,000 units of heparin, 500 milligrams of methylprednisolone IV. Then the vascular clamps are placed on the pulmonary artery and the inferior pulmonary vein. and the pulmonary vein, the pulmonary artery, and the bronchus are divided in this order. The vascular stumps are sutured with 5O polypropylene running sutures. The bronchus is closed with 4O PDS and is covered by the pericardial fat. Interrupted sutures, and the back table, the team at the back table starts to flush the graft with the lung preservative, both antegrade and retrograde, and the grafts are gently ventilated with room air. The recipient at the other room has his clamshell as shown. It's bilateral anterolateral thoracotomy with transverse sternotomy. We do the hilar dissection is performed before hyperonization to minimize blood loss. We use now the central ECMO instead of the conventional cardiopulmonary bypass. Two drainage cannulae are put, one to the right atrium and the other into the femoral vein, the right femoral vein. The ascending aorta is cannulated. Then we proceed to do the right pneumonectomy. Then the right lower lobe graft is implanted. The bronchus, the pulmonary vein, and the pulmonary artery are anastomosed in this order. The pulmonary vein anastomosis is performed between the donor inferior pulmonary vein and the recipient upper pulmonary vein, leaving the airing procedure at the time of reperfusion. Then the pulmonary artery anastomosis is conducted in an end-to-end fashion. 500 milligrams of methylprednisolone is given IV and nitric oxide inhalation is started. Then antegrade reperfusion and de-airing is done to the graft by releasing the vascular clamp of the pulmonary artery. And after the right graft is perfused and ventilated, the ECMO flow is decreased gradually to 70% to allow proper perfusion of the graft. Then we proceed to left pneumonectomy and do these steps again. And after both lungs are reperfused, the ECMO is gradually weaned, and actually it is removed when the hemodynamics and blood gases are satisfactory. Here are the results. The living donor lung transplantation provides similar survival to cadaveric lung transplantation, even for very ill patients. It's coming from Kyoto. Regarding our challenges here in Ain Shams University, Cairo, we had some mandatory objectives to avoid the failure rate of new programs which exceed 40%. We had to sustain the program. We had to define the quality measures and to carefully plan for the institutional proficiency, the medics, the nursing, the supporting system, the administration, finances. So we contacted many different parts of the world operating in this field. First, we contacted Japan, and kindly Professor Date has welcomed us in his department, actually 2 times. A team comprised team of a surgical team, chest department, intensive care, anesthesia, and radiology has went there. A colleague is now in China studying the lung pathology. Another move was done with King Faisal Specialized Hospital in Riyadh, and we dispatched another team there, surgery, anesthesia, ICU, pathology, radiology, physical medicine. We had some training programs, ECMO programs in Italy, and one of our colleagues has gone to the United States for the anesthesia and intensive care regarding the lung transplant. So that was a very nice email I've got from Professor Date approving our visit to Japan. And actually at the Kyoto University Hospital, we had an excellent and convenient workspace Most of the transplant meetings there were instantly translated into English. We had access to the transplant video library. This was very important. It had different cameras from different angles. We had access to all the transplantation activities, the research publications, bronchoscopic interventions, intraoperative attendance, revision of the transplant morbidity. The resume, actually, of the transplant meeting was in English. We were involved in frequent MDMs twice daily for the whole department, pre and post-transplant meetings, joint thoracic oncology meetings, chest department radiology and pathology meetings, inpatient morning rounds, and we had access to the daily progress of the patients at the intensive care unit. For the radiology, they had a full acquaintance with the 3D reconstruction software, and it's installed now in Ain Shams University, in Shams Specialty Hospital. The Anaesthetic Protocol, including the ECMO protocol and preoperative evaluation, were studied well. The intraoperative advanced monitoring for the anesthesium, the IMVOS, the TE, operative TE. The intensive care unit, the immunosuppressor protocol, and the determining requirements of drugs, equipment, and disposals. For the pulmonology, they had attended a daily activity with the pulmonology department, outpatient clinics, lists of fiber optic bronchoscopies. They had a complete recognition of the medical registry of the patients with respiratory disorders, especially potential patients for lung transplant. They obtained the respiratory lung transplant protocol with discussing it with the Japanese pulmonologists with a point-to-point clarification, and viewing and discussing the Kyoto Hospital guidelines concerning other respiratory diseases. For us, thoracic surgeons, we knew well the eligibility for lung transplantation, the general inclusion and exclusion criteria, the size matching, the function anatomical as covered by Professor Date, the waiting list management, the safe donor lobectomy, it is very important, and the sequence of events, the choice of operation, and the use of the perioperative extracorporeal support, ECMO versus the cardiopulmonary bypass, the management of the complications, and the size mismatches. We had a knowledge of different strategies for management of size mismatch, like oversized grafts and undersized grafts as covered. For the Saudi group, they were welcomed at the King Faisal Specialized Hospital and Research Center. They had stated that they will give us full support in the surgical and medical aspect the first year of starting the program, along with our Japanese counterparts. We had complete acquaintance to the rejection pathology. We had a pathologist there, especially for the lung transplant pathology, and the pre and post-operative management of transplanted patients. The surgical exposure there was only to the cadaveric lung transplant. They managed to cover with us the first cadaveric lung transplantation workshop held in December 2018 on real cadavers. The third was approaching the Academy of Scientific Research and Technology through some work packages, the capacity packages, to start to approach the population, the study visits, the expert importation, to hold conferences, workshops, to guide the society, to orient them about this kind of operation, to carry out local visits and to local national visits. They have agreed to provide us with a research fund which will help us to carry out this project. And these are the current renovations of Ain Shams Specialized Hospital with the complete renovation of Building D, ICUA, the renovation of the OR, the bronchoscopy unit. And we have actually obtained most of the essential medical supplies and equipment necessary to start the program. Lastly, we have some lessons learned. We have to stick to one project at a time, concentrating on its objectives. We have known the significance of the scientific research, which comes before even the actual surgical training, the importance of the supporting staff. Now the whole team speaks the same language. For example, we know the importance of the early tracheostomy. We know the importance of the rehabilitation. Rejection. This is very important, and we will find a common language to speak with. Establishing and updating a reference protocol, all personnel adhere to in most of the classic cases. And this point is very crucial. The importance of the regular meetings, exchanging opinions, specific job prescription for every medical personnel, and at last, the teamwork and collaboration. So here's our team. The thoracic surgery team is from Ain Shams University and from King Faisal Specialized Hospital. The pulmonology, the intensive care, the anesthesia, physical medicine, radiology, pediatric pulmonology, tissue compatibility. And lastly, I would like to address Professor Datei. We really appreciate your support in this endeavor. You have been extremely supportive. I want to acknowledge the extra effort carried out by our Japanese colleagues at your department. Thank you for sharing your knowledge and experience with us. And we cannot wait to welcome you in Cairo soon. And for Professor Mahmoud Al-Mitini, the president of Ain Shams University, we are very grateful for your sincere help and prompt action starting this project, injecting enthusiasm and solving out difficulties. And lastly, for Professor Ashraf Omar, the Dean of Faculty of Medicine at Ain Shams University, thanks for your support and understanding, hoping to meet your expectations soon. Thank you very much. Any questions?
Thank you, Dr. Ahmed Mustafa, for this nice and hard job you are doing with your team to introduce lung transplantation in Ascot Center. We are looking forward to another successful story to be added to our
Inshallah. Thank you very much.
Now we know that nutrition is crucial issue in preparatory and recovery period of transplant patients. Our team, transplantation team, is not completed without some modification in the program.
Our next talk will be about Dr. Sara Ali and Dr. Dina Azdin. Role of clinical nutrition in LDLT.
طبعا liver transplantation أو transplantation work never completed without clinical pharmacology, not only for the immunosuppression, but the patients are critically ill. They are having comorbidities and manipulation of doses and calculations. And they are doing great effort in this issue. It's my pleasure to introduce our clinical pharmacists and nutrition specialists, Dr. Sara Ali and Dr. Dina Azdin, to give us their experience in nutrition in liver transplantation.
Okay. Thank you, chairpersons, moderator, Dr. Yasmin. Thank you, Dr. Mahmoud, for this nice celebration. Thank you, our mentor and my colleagues. النهارده التوبيك بتاعتنا احنا هنتكلم عن الرول اوف كلينيكال نيوتريشنست. احنا بنمسك البيشنت من اول ما يبقى بري ترانسبلانت وبيبقى معانا في البوست ترانسبلانت كمان، من الدونر او الريسيبينت او البوست دونر وريسيبينت. احنا النهارده هنتكلم عن الدونرز، التحضير بتاعه، donor with non-alcoholic fatty liver disease, should we reject or accept? This is our agenda for today. من 2016 احنا كان عندنا ان احنا بناخد الليميتيشن شويه في الدونرز، ان احنا بناخد ريليتد دونرز. بقى عندنا في اكستندد كرايتيريا ان احنا ممكن ناخد الدونر بهاي بي ام اي. المشكله ان هم كمان مش بيبقوا اوبيز. في عندي 30% of the donors بيبقوا not obese. اللي بيبقوا obese patients او obese individual ممكن ان انا اعمل لهم دايت، لكن الفكره ان انا ال 30% دول اللي مش obese ما بيبقاش عندي فكره الليفر بايوبسي بتاعتهم ان هي يبقى فيها ستياتوزس. بيبقى الفيرست ايفنت في النون الكحوليك فاتي ليفر ديزيز جينيسيس في الليفر فات اكيوميليشن انديوسد بالتشينج في الليبيد ميتابوليزم، وده بيخلي فيه اكيوميليشن للفات سيلز على الهيباتوسايتس. تاني حاجه ان هي بيبقى فيه excessive production للرياكتيف اوكسجين سبيشيز جنريتد بالميتوكوندريا، وده بيعمل شويه انفلاميشن ممكن نلاقيها في البيوبسي. الاسسمنت بتاعنا بيبقى فيه لابوراتوري انفستيجيشن، بنشوف الليفر انزيمز، الليبيد بروفايل، ال HbA1c عشان لو الدونر كان عنده سايلنت دايابيتس. بنشوف الانثروبومتري الويت، بنعمل له الان بادي امبيدنس. بنشوف هيب تو ويت ريشيو، واهم حاجه السكين فولد كاليبر، ده بنشوف بيديني امبريشن عن الفيزرال فات ليفل بتاعت الانديفيدوال ده. بنعمل راديولوجيكال وباثولوجيكال طبعا انفستيجيشن، الابدومينال الترا ساوند، والجولد ستاندرد فور دايجنوزس عندي ليفر بايوبسي. باي ريدكشن للويت ب 5% انا بقلل الاستياتوزس، بس ما بيبقاش فيه اي امباكت على لو كان فيه ناش. لما بقلل الويت ب 10% بيبقى فيه طبعا ريزولوشن للاستياتوزس، بيبقى فيه ديكريز للناش، وبيبقى عندي امبروفمنت في الفايبروزس بوان ستيج. كل السوسايتيز سواء كانت ليفر سوسايتي دايابيتك او نيوتريشن اكدوا ان انا لازم اعمل موديفاينج لللايف ستايل للبيشنت والفيزيكال اكتيفيتي، وان انا اديله هايبوكالوريك دايت. بالنسبه للدايت اللي احنا بنديه للبيشنت، احنا بندمج حاجتين، بنعمل ميديترينيان دايت مع كولين بيزد دايت. مبدئيا هو بيبقى بلانت بيست، بنديله هول جرين ليجيومز الفروت والفيجيتابلز، بيبقى فيه لو في الكربوهيدرات، بنديله مونو ساتوريتد فاتس، وبنديله طبعا اللين ميت والديري برودكتس عشان بيبقى فيها كولين. بندي برضه للبيشنت بيرسوناليزد اكسرسايز اكتيفيتي على حسب كل دونر الفيزيكال اكتيفيتي بتاعته عامله ازاي. ممكن نعمل نديله سبلمنت زي اوميجا 3 سبلمنت او ال كارنيتين عشان الفات ميتابوليزم، وفيتامين اي وكولين سبلمنتس. الاوتكمز بتاعتنا احنا ابتدينا من 2016 عملنا 5 بيشنتس، انتهينا من 2021 و2020 كان 31 and 28 patients 2020. البي ام اي بتاعنا كان من 23 ل 26، ودول كانوا نون اوبيز بيشنتس، والماجوريتي بتاعتنا كانت 27 to 30، واكثر من 30% او 30 بي ام اي كان تقريبا في 20 دونرز. التوتال نمبر اوف كيسز كان 92 دونرز. النون اوبيز كانوا 22%. كان عندنا فيلير ريت عشان ما عرفوش ان هم يمشوا شويه على الدايت ريستريكشن بتاعنا، و 65% كان obese patient في الستاديز. ده اكزامبل للهيستوباثولوجيكال ريبورتس، بيبقى فيه 15% او اكتر في الباثولوجي ريبورتس بنوصلها ان احنا بيبقى فيه no steatosis. The summary limitation to only related donor give us the chance to accept the donation of non-alcoholic fatty liver donors. الانثروبومتريك measures يا ريت ان هي تتعمل في الايرلي اسسمنت فيز بتاع الدونر، والدونرز كلهم لازم يحصل لهم modification لللايف ستايل. Thank you.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure and honor to present in front of my professors and my mentors. And special thanks to Professor Dr. Mahmoud, who gives me the chance to be a member of such scientific leading and pioneer team in living donor liver transplantation. Our agenda for today includes introduction, etiology of malnutrition in end-stage liver disease, impact of sarcopenia as a consequence of malnutrition in pre-transplantation phase, assessment of nutritional status, goals of nutritional therapy for end-stage liver disease patient waiting for liver transplantation, basic nutritional recommendations, general recommendation for end-stage liver disease patients waiting for liver transplantation, special micronutrient supplementation and reference. Introduction. The liver is the largest and most crucial metabolic organ, playing a pivotal role in integrating several biochemical pathways of carbohydrates, fat, protein, and vitamin metabolism. Malnutrition is a common complication of end-stage liver disease. About 20% of patients with compensated cirrhosis and 50% of patients with decompensated cirrhosis suffer from deterioration of nutritional status, and this may lead to poor outcome. Liver transplantation revolutionized the management of liver disease, as it is the only option for those with end-stage liver disease. Prolonged waiting times worsen outcomes when patients are already malnourished. The etiology of malnutrition includes, first, the hypercatabolic status due to increase in the basal energy expenditure due to increased sympathetic nervous system, inflammation, fever, peritonitis, bacterial translocation. Also increase in insulin resistance due to decreased glycogen stores, decreased glycogenolysis, increased gluconeogenesis, and increased lipid peroxidation, and increase in amino acid mobilization. Decrease in insulin growth factor 1 due to increased growth hormone resistance. Secondly, due to decrease in nutrient absorption due to drug-induced diarrhea such as antibiotics, lactulose, diuretics, antimetabolites, cholestyramine, or due to fat malabsorption as a result of alcoholic liver disease, cholestatic liver disease, inflammatory bowel disease, pancreatic insufficiency, or due to delayed bowel function recovery from surgery or gastrointestinal reperfusion injury, immunosuppressors, and corticosteroids. Thirdly, due to decreased caloric intake as a result of anorexia from zinc deficiency, hyperglycemia, increase in tissue necrosis factor alpha, leptin, interleukin-6, H. pylori infection, or due to unpalatable diets due to low salts and low protein, altered gustatory sensation due to hypomagnesemia, autonomic neuropathy, early satiety due to tense ascites, decrease in GI peristalsis or organomegaly, or due to increase in protein losses due to a GI bleeding, portal hypertensive, gastropathy, and paracentesis. Impact of sarcopenia as a consequence of malnutrition in pre-transplantation phase. Sarcopenia is a frequent complication in patients with end-stage liver disease awaiting liver transplantation and a major component of malnutrition. It is defined by loss of muscle mass, decrease of functional capacity, which is complex and multifactorial states include poor nutritional intake, protein catabolism, and physical inactivity. Sarcopenia can significantly increase the operative risk at the time of surgery and is a risk factor for morbidity, short and long-term mortality in patients undergoing living donor liver transplantation, and decreased graft survival after the surgery. Also, it could interfere with early post-operative mobilization. This is the factors contributing to sarcopenia: decreased food intake, imbalanced protein synthesis and catabolism, altered gut microbiota, leaky gut, increased lipid oxidation, ketogenesis, decrease in activity due to increase in myostatin, and decrease in insulin growth factor 1, leading to increased gluconeogenesis and glycolysis. Sarcopenia confers a vulnerability to preoperative infection, includes spontaneous bacterial peritonitis, pneumonia, sepsis, non-dehiscence, pulmonary complications, including aspiration pneumonia, and atelectasis secondary to deteriorated immune functions. Moreover, patients' nutritional status can worsen rapidly, which predispose the patient to complication post-living donor liver transplantation, as compromised respiratory function, wound healing problems, longer dependency on mechanical ventilation, increased rates of septic complication, use of antibiotics, blood products usage, length of hospital stay, intensive care unit admission, delayed physical rehabilitation with substantially higher cost of transplant. Assessment of nutritional status. All patients being prepared for liver transplantation should undergo through nutritional evaluation. Traditional assessment tools as BMI and anthropometry are not accurate in end-stage liver disease due to fluid retention and organomegaly found in a significant number of patients. No gold standard evaluation exists to determine the extent of malnutrition in patients with end-stage liver disease. Some tools used in assessments, such as subjective and global assessment, biochemical parameters of nutritional status, such as serum transferrin, retinol binding protein, serum albumin, prealbumin, immune competence, anthropometry, body mass index, mid-arm circumference, pinfold thickness, hand grip dynamometry, including 6-minute walk test, indirect calorimetry, bioelectric impedance, and others such as index. Our goals: timely nutrition assessment and patient-tailored intervention for recipients on the waiting list, improves the outcome for liver transplantation. According to ESPN guidelines, aggressive nutrition implantation for 10 to 14 days prior to surgery is recommended to end-stage liver disease patients listing on the waiting list. Prevent further nutrient and muscle depletion and to correct any vitamin and mineral deficiencies through preemptive nutritional support and liver-adapted formula containing needed macronutrients, especially branched-chain amino acid, in order to minimize the risk of infection and disability. Reduce preoperative complication and improve the quality of life. Educated patient with caregivers on individual plan for nutrition and level of activity. Nutrition recommendation: calories and energy needed from 1.2 of a basic energy expenditures, about 30 to 35 kilocalories per kilogram per day, divided into 6 small frequent meals with bedtime meals containing complex carbohydrate, using dry weight for calculation. Carbohydrates from 60 to 70% of non-protein calories. Restrict simple carbohydrates, protein from 0.8 to 1 kilogram of dry weight in compensated liver disease, and from 1.2 to 1.5 gram per kilogram dry weight in decompensated liver disease, 0.6 to 1 gram per kilogram dry weight for hepatic encephalopathy. We're using a branched-chain amino acids enriched form. Fats from 30 to 40% of non-protein calories, using a medium-chain triglyceride when straturrea is present. Using omega-3 is preferable. Fibers from 25 to 45 grams per day. Fluid in sodium 1,000 to 1,200 milli in case of hyponatremia less than 125. 2 to 3 grams of sodium in case of ascites edema. Vitamins and minerals, dietary reference intake or pharmacological doses in case of deficiency. General recommendation: monitor the calorie count frequently and consider supplementation if the oral intake is suboptimal. Smaller and more frequent meals are better tolerated. Protein restriction shouldn't be performed routinely to prevent aggravating protein deficiency. Hepatic encephalopathy should be treated aggressively before protein restriction using a branched-chain amino acid. Patients should take daily vitamins, calcium supplementation in case of osteoporosis and osteopenia. Exercise and physical activity using both endurance and resistance exercise. Especially micronutrient supplementation in case of alcoholic liver disease, supplementation vitamin B1 and 6, B12, folate and zinc. Cholestatic liver disease, supplementation with fat-soluble vitamins. Non-alcoholic steatohepatitis ensure adequate diabetes and hyperlipidemia management, supplementation vitamin D. Other chronic liver disease, such as viral hepatitis and autoimmune hepatitis, supplemented vitamins and minerals as required. Thank you.
دكتورة دينا ودكتورة سارة. وحقيقة جزء الكلينيكال نيوتريشن وجزء الكلينيكال فارماسي معانا مهم جدا. يمكن كان عندي لسه مريض جاي يزرع ليفر وكدني، وكان وزنه 120 كيلو، وكان جاي عشان يعمل دول جرافت ليفر واحد كده، بس هو كان شايلد يعني نقول بي 8 كده 9. فبعتناه لحد من زملاء النيوتريشن، قلت له عشان ده وزنك كبير قوي نقلل الوزن شويه يمكن نلاقي متبرع واحد يكفيه. الحقيقه عمل دايت فعلا ونزل معاهم حوالي 20 كيلو. اصبح وزنه يكفيه دونر واحد. الغريب ان الليفر نفسه اتحسن بعد القصه ديت، وبقى مش محتاج اصلا ليفر ترانسبلانت ورجعناه تاني للكدني ترانسبلانت ان هو يزرع الكلى فقط، وحتى اللحظه دي ما زرعش الليفر اللي كان عنده. فيعني ثانك يو طبعا للمجهود اللي بتعملوه معانا، وجزء برضه الكلينيكال فارماسي بتاع الدكتوره ساره برضه مهم جدا في الادويه وتظبيطها، هي شايله علينا عبء كبير جدا.
Another story of success by ASCO team, which is renal transplantation experience in 10 years experience, will be presented by Professor Dr. Nahla Taima.
السلام عليكم. أحب أهني حضراتكم بالإنجاز 1500 حالة ليفر ترانسبلانتيشن، ودايما بالتوفيق يا رب. نتكلم بقى عن الرينال ترانسبلانتيشن 10-year experience. Back in 2006, kidney transplantation started in Inchams University Specialized Hospital on individual basis for some blood-related patients with charity funding and individual payments. By 2010, the kidney transplantation program in Inchams University was officially launched in synchronization with the organ transplant law, where necessary directives were made by Higher Committee for Organ Transplantation setting the cardinal rules to be followed by our transplant team. Incham Center for Organ Transplantation team, we all work hand in hand, physicians, nurses, social workers, other professionals, for improving patient selection outcomes and future perspectives. It was early started by our dear professors, Professor Dr. Sabri Guhar, Professor Dr. Asam Khadr, Allah yarhamu, Professor Dr. Yasser Silman, and Professor Dr. Magdi Shar'awi. Our current transplantation team is led by Head of Liver and Kidney Transplant Program, Professor Dr. Mahmoud Al-Mitini. Professor Dr. Magdi Shar'awi is the Program Manager, and Dr. Walid Anwar. This is the current team of kidney transplant unit. Also, urology team transplantation, Professor Dr. Muhammad Asmat, and vascular surgeon, Dr. Tariq Abdelazim. Our unit transplanted a total of 213 patients since 2006 till date. Indications for transplantation were end-stage kidney disease caused by the most common etiologies: عندنا glomerulonephritis, hypertensive nephrosclerosis, pyelonephritis, polycystic kidney disease, obstructive uropathy, and diabetes. Our donor criteria is living blood-related individuals only, age 21 to 50 years, APO compatibility, BMI less than 28, serologically negative for HIV, free from any chronic medical conditions, psychologically stable, non-drug or alcohol abuser, and female donors should not get pregnant for 1 year and not on hormonal therapy. We have special situations. Our unit performed preemptive transplant procedures for about 20% of our candidates, with ultimate renal replacement therapy, improved patient and graft survival, high return to work rates, and better quality of life and lower long-term medical costs compared with transplantation after dialysis initiation. Also, in 2020, we have combined liver and kidney transplantation was performed in one patient with cirrhotic advanced liver disease associated with HCV-related MPGN causing end-stage kidney disease. Moreover, 5 children were transplanted through our program with an excellent graft course. This is the number of transplant patients per year. We have mortality, we have total number of patients 213 with mortality 1.6% by year of 2021. Main causes of mortality were cardiac events, overwhelming sepsis, and post-operative complications or hemorrhage. Graft rejection rate was estimated to be 2 to 4% All grafts were salvaged by medical anti-rejection protocols, ending in graft survival rate of 100%. There were no patients who needed to be maintained back on regular hemodialysis. This is our team, and thank you.
Thank you, Professor Nahla, for your elegant and concise talk. Last but not least, I would like to introduce Dr. Muhammad Sobhi and Dr. Muhammad Shaker, professors of interventional radiology and the cornerstone for the liver transplant team.
First, I'd like to thank Dr. Mahmoud Al-Mitani and all the other members of the team, and to express my happiness and being proud that I am a member of this team for this long time. We'll talk about complex cases of intervention radiology. So the role of intervention radiology in liver transplantation is mainly two issues: bridging and downstaging of HCC patients and managing vascular and biliary complications. If we talk about managing complications, we begin with two cases of graft artery stenting. This is a patient, a female patient, 25 years old, had liver transplantation in January 2020 for liver cirrhosis due to autoimmune hepatitis. At the beginning of her fifth week, she was still in hospital. The hepatic artery was not visualized in routine Doppler examination, and her labs revealed elevated transaminases. And usually when you do not see the artery with the same machine and the same person, usually there's a problem. And so the Doppler examination revealed non-visualization of the artery. The graft was still homogeneous, so we decided to go for CT. The CT showed high-grade anastomotic stenosis at the surgical anastomosis and non-filling of distal branches of the graft artery, and the graft was still healthy with no infarctions. We can scroll down and up on the workstation to see that the artery is not passing the stricture. The dye is not passing the anatomic stricture on CT. And if we go for the static images, we can see that the artery is abruptly stenotic at the surgical anastomosis. So we decided to do emergency stenting. Of course, a delay in this decision you can lose the graft, and sometimes you can lose the patient. So this is the initial angiography. We see the high stenosis at the anastomosis. Interesting. How can I point? Okay. So after passing the stricture with 0.14 wire and using balloon-mounted drug-eluted coronary stents, then the stent is deployed, and we can see here the long stent deployed across the stricture. And afterwards, we can jump to the end angiogram, showing good filling of the artery and the distal branches. So this is before intervention and after intervention. We can see the artery is now clearly visualized in the final angiogram, and before and after the Doppler before and after intervention. Another patient, male, 51 years old, had liver transplantation on March 2020 for chronic liver virus C infection. At the beginning of fifth week, he was still having a surgical drain because of biliary leak, and his artery was also not visualized by Doppler and with elevated liver transaminases. So we ordered CT. We cannot. Here we are trying to visualize the artery by Doppler. We are only getting portal flow. No arterial flow can be detected by Doppler. So we went to CT. And with CT scrolling up and down, we cannot see the artery passing within the graft. Very minimal opacification of the artery proximally, which means that there is high-grade stenosis, and also the graft is still healthy with no infarctions. So we decided to go for emergency stenting. So we can see this is the beginning, the opening angiogram. We can show the high stenosis at the anastomosis. And then placing also 0.14 wire and the coronary artery drug-eluted stent and deploying the stent across the stricture. And we can see here the final angiogram showing good opacification, and we can see that the terminal branches of the artery show good filling with contrast, revealing good patency of the artery. And this is before and after the intervention. And this is the Doppler study before and after placing the stent. Another potential complication is portal vein stenosis. We have here a case of portal vein. Improving despite in the routine Doppler, we also noticed that there is tripling or quadrupling of velocity across the anatomic anastomosis, and there is stricture and the portal vein anastomosis. So we went to CT, and we can here see by scrolling up and down that there is a high-grade stenosis at the beginning of portal vein. So we decided to do portal vein stenting. So portal vein stenting was done percutaneously. We went through the posterior branch because it was more in line with a main portal vein, and we placed a wall stent, self-expandable stent. And we can see afterwards that the velocity of the portal vein is normalized, and we can see in the PMUD image the stent deployed across the stricture. I will also show a case of bridging of HCC for liver transplant. This is a 57-year-old patient presented with 2 hepatic focal lesions in January 2012. He was child B7. His albumin was 2.9, as bilirubin about 2. So when we had these 2 lesions in CT, one on the left lobe segment 3 and one in segment 8. So we decided to go for radio frequency. So after radio frequency, we had this residual lesion in segment 8. So we decided to alpha fetoprotein dropped to 216. So we decided to go for TACE. TACE was done with good results, and after 1 month, it was good. But at the 4th month, post TACE, he had rising alpha fetoprotein again, mild ascites. So CT chest was free, but we had rising alpha fetoprotein, and we were thinking about transplantation. So we went to PET-CT. In PET-CT, we had activity in segment 3, and we went for RF. The difficulty of this lesion is that it was not visible in ultrasound or non-contrast CT. So we did CT-guided radio frequency. And the patient was stabilized 3 after radio frequency, and his alpha fetoprotein drops to 10 after 6 months, and he received liver transplantation at the end with left lobe graft. The CT post the TACE before transplantation. So we went for liver transplantation, and this is the left lobe graft, graft rate ratio 0.7, and his explant showed necrotic segment 3 and partially necrotic segment 8. Thank you very much. I think Dr. Muhammad Shaker will be next.
شرفنا النهارده الدكتور محمد شاكر، هو اخ عزيز جدا علينا، وانا يعني انترفنشن راديولوجيست في مصر الحقيقه. واتفضل دكتور محمد.
السلام عليكم جميعا. First, I'd like to thank Professor Dr. Mahmoud Meteni and the organizing committee for inviting me to participate in this scientific meeting, and I am surely honored that I was a member of this distinguished team, and we worked a lot together. So I will present a case. Actually, it is not a complex case. However, it is rather a case of discussion and decision making. So I named the case HFC from palliation to cure. This is a chronic liver disease female patient, 59 years old, child A5, presented with right hepatic loop infiltrative hepatocellular carcinoma, as you see here, involving almost most of the right hepatic loop with malignant thrombosis of the right portal branch, enhancing thrombus, occupying the whole right portal branch. This was in December 2013. We decided to do radio embolization, Y90 injection for this lesion. And this was the follow-up 3 months later. If we compared, this is pre and this is post, we can see necrosis of most of the lesion, and the right portal branch tumor thrombus now is non-enhancing in the arterial phase compared to the enhancement in the pre-injection phase. So it became now inert portal vein thrombus. However, there is some enhancement at the margin of the lesion, so we decided to continue by doing transarterial chemoembolization. And this was the result with some lipidol density at the margin of the lesion. And during the follow-up in May 2014, we noticed another small de novo lesion at the left lobe. It's about 2 centimeter lesion. However, being exophatic, as you see here, we decided to do TACE instead of local ablation for fear of rupture or bleeding during the ablation of this lesion. This was the follow-up in June 2014. As you see here, the left lobe lesion is completely occupied by the dense lipidol, reflecting satisfactory response to TACE, and the right lobe lesion is now completely necrotic with no enhancement. This patient actually was very compliant on the her follow-up every 3 months by the triphasic CT and the full lab. This was 1 year later, as you see here, complete necrosis of the right lobe lesion and non-viable left lobe lesion and no de novo lesions. 1 year later, in August 2016, the same, with no new lesions. In October 2017, atrophy of the right lobe, what we say or name the radiation lobectomy with hypertrophy of the left lobe. And we can notice here the recanalization of the right portal branch, complete recanalization with no residual thrombus inside. We continued follow-up. This November 2018, the same, the condition is still stable with no new lesion, and again here, complete recanalization of the right portal branch and the complete necrosis of the right lobe lesion with atrophy of the right lobe and the marked hypertrophy of the left lobe. This 1 year again later in November 2019, the same, and the case is stable, still child A, no de novo lesion, and the treated lesions are completely necrotic with no viability. And then the patient disappeared after the era of the COVID. Actually, I don't know if she's still living or not. However, the question here is this before and 6 years later. So the question now regarding this patient, if this patient is still alive with stable condition, no de novo lesion, regarding the previously known malignant portal vein thrombosis, however, with 6 years survival, with no de novo lesions, with complete recanalization of the portal vein. So the question is, to be or not to be? So to transplant or not to transplant?
هي واضح انها lucky ان البيولوجيكال nature of the tumor يعني is not aggressive and no recurrence all through the period. يعني we can follow up بخصوص انها child A بس close follow up of monitoring يعني.
Okay. دكتور محمود.
طبعا she is indicated for transplantation.
6-year survival after radio embolization. The patient was having right portal vein malignant thrombus, and 6 years later she's stable. The thrombus recanalized, no viable tumor tissue, and no de novo lesions. At this, it was about 65. 65, child A with no good general condition with no recurrent tumors. No. This is the beginning in 2013. And this is the last one, complete necrosis of the lesion with recanalization of the right portal vein. No photography, CT images. This is the right portal branch compared to this. Yes. To be transplanted. Okay. So do we have now consensus for transplanting these patients with previously malignant portal vein thrombosis? Okay. Very good. Okay. Thank you very much.
It's very difficult to give a decision, but if the patient is willing, we have to consult with the patient and see what's her hope and expectations. She might prefer to go on the follow-up since she was in 6 years on follow-up and she's child A and no tumor recurrence. But I think the patients and the will of the patient will get us there for the answer. Because it's really it's equivocal whether to go there. She's good, she's having good life 6 years after HSC with no recurrence, good tumor behavior. However, on the other hand, we all know that the recurrence is coming anyway. So
يعني بالنسبه لي هو في تو ايشوز في الحاله ديت. الايشو الاولاني زي ما دكتور محمود قال قصه المالجنت بورتال فين ثرومبس، هل ده كانديد فور ترانسبلانت ولا لا؟ واعتقد ان في بيبر كتير على القصه ديت وحطوا زي كريتيريا ان لما نعمل تير وان التيومر يبقى نيكروزد، الالفا بروتين ترجع للنورمال، وان البورتال يبقى بيتنت. لو تحقق الثلاث حاجات دول تستنى من 6 شهور لسنه لو هو ستيبل يو كان ترانسبلانت. فدي الايشو الاولاني اللي هي ينفع ازرع ولا ما ينفعش، دي كنقطه. عملته كله يعتبر كده فهي تنفع تزرع، لكن هل هي محتاجه تزرع؟ ده السؤال الثاني. برضه في مشكله في القصه دي. احنا عندنا في حاجه اسمها سالفج ترانسبلانت. سالفج يعني لما هيجي لي عيان عنده اتش سي صغيره اتعامل معاها ولا ازرعها؟ في ديبيت، في ناس بتقول لا ممكن اعمل ريسكشن ولما يحصل ريكارنس اعمل ترانسبلانت اذا سالفج ترانسبلانت. لكن وانس ان حصل ريكارنس اتس انديكيشن فور ترانسبلانت. هنا انت عندك مشكله، عملت ليجن، هنعتبر انك تعاملت معاه بالتير بس طلع لك ليجن ثاني تعاملت معاه بالتيس. ف if we consider الليجن الثاني ده اذا ريكارنس then it is an indication هنا ان انا اعمل ترانسبلانت. طبعا برضه اجينست القصه ان انت كسرت كل الرولز. احنا على طول بنقول ان التيست اذا باليتيف. هنا قاعد تدسي ما اعرفش ازاي.
هي بالنسبه لحته التيست بالياتيف دي هي الدنيا بتتغير خالص. يعني هي المفاهيم كلها اتغيرت في الكام سنه الاخرانيين. هو ما بقاش بالياتيف، هو التيست بقى يتعامل خلاص كبوتنشال كيوراتيف تكنيك. والدليل انه او مش الدليل، يعني احنا من زمان طلع ستادز كتيره جدا وميتا اناليسيز كتير، وقالت ان التيس لا كان انكريس سرفايفل وكان امبروف السرفايفل. والكلام ده يمكن اول بيبر اتكلمت على الكلام ده كان عاملها بروش سنه 2002، وقال ان تيس انكريس سرفايفل وامبروف السرفايفل، وطلع بعديها ستاديز كتير وميتا اناليسيز كتير.
سواء انكريس سرفايفل حاجه، وان انا احطه تحت كيوراتيف تريتمنت. احنا عارفين على طول الكيوراتيف تريتمنت يا ريسكشن يا ترانسبلانت يا ار اف اقل من 3 سم.
صحيح،
دول الثلاثه اللي حددنا.
صحيح، هو لسه ما اتحطش بشكل رسمي تحت الجروب دي في لكن بقى يتعامل فعلا كبوتنشال كيوراتيف تريتمنت، لانه خلاص بيمبروف السرفايفل وبنوصل ل5 سنين سرفايفل زي ما احنا شفنا في الحاله دي.
كده دي لو اعتبرت ان دي ريكارنس ف ده انديكيشن للترانسبلانت المفروض. بس برضه الغريب ان احنا قعدنا بعد التيست 4 سنين او 5 سنين،
5 سنين
ما ظهرش نيو ليجن، وبالتالي هل ممكن تكمل اكتر من كده وذات نيو ليجن؟
ما هي بقى ذيس ذا بوينت، ان هي يعني انا كنت كل مره بتجيلي فيها كفولو اب، طب نزرع بقى يعني. فهم كانوا مترددين جدا في الديسيجن ده، لان هم شايفينها كويسه وما عندهاش مشكله وفي جود جنرال كونديشن ومفيش ريكارنت، طب خلاص هنزرع عليه. فده كان وجهه نظر البيشنت والريلاتيفز بتوعهم.
يعني دي لو كانت جات لي في بعد التيست مباشره كنت اقول لها لازم تزرعي، لان يعني ريكارنس مينز ترانسبلانت خلاص. لكن هي المشكله جت بعد 5 سنين، يعني قصدي لو كان ريكارنس هيحصل ما حصل في 5 سنين.
تمام.
يعني فعلا الاجابه صعبه جدا.
هو بعد اذن حضرتك دكتور محمد، هو فعلا احنا ممكن نعتبر ان العينه دي اتعملت زي سهله ليفر سكشن، عملت السكشن وكلوز فولو اب، لما يظهر ليجن جديد اكيد هنشوفه وهو صغير وهنزرعه. لا، اما هو قعدت 5 سنين بعدها مفيش حاجه. فولو اب يعني انت ممكن حاجه فعلا احنا ممكن ما نزرعش، احنا ممكن نشوف العينه دي بعد كلوز فولو اب كل 3 شهور او كل 6 شهور ظهر ليجن جديد تزرع. تمام. بس هو احنا 5 سنين. لا انا اقصد ان احنا لو في كلوز فولو اب كل 3 شهور فعلا، هو الليجن مش هيبقى سنتي اول ما يظهر او 2 سم بالكثير.
تبقى ساعتها فيت فور ترانسبلانت.
تمام، اوكي، ثانك يو.
يعني at the end of this day الحقيقه انا في غايه السعاده النهارده. اولا اللي انا هربت من الجامعه وقاعد معاكم مش عايز امشي من هنا، يعني اللي انا هربان من المكتب فمبسوط جدا. بس الست المستشار ما سابنيش وجالي يقول لي المشاكل اهو. Thank you very much for the wonderful day بيكم كلكم، والحقيقه very well prepared program. شكرا لكل الفريق، كل واحد حضر وقال فكره فيه، وشكرا للشركه المنظمه، وشكرا للاندستري والسبورتنج اندستري. ايرس طبعا دايما معانا، اشرف بدوي وفريق كله، شكرا لاشرف. وثانك يو فور اندستري نوفارتس ساندوز، حطيت النيمز بتاعتهم هنا ولا لا عشان ما انساش حد، والحكمه طبعا فور كامينج في عين شمس كمان. and I'm very proud and happy بالفانيو. في شويه bits and pieces فاضله ان شاء الله هتكمل، لكن I think بقى all our meetings will be here or in بنهاوي in عين شمس, whether our friends from elsewhere or from عين شمس. هيبقى ال congresses for all specialties, please do it here. هيوفر لكم كتير. اولا يخلوا الشركات بسهوله تتعامل معاكم، واشرف ما ياخدش فلوس خالص، فالدنيا تبقى سهله قوي هنا. و thank you for the liver team, for the kidney team, and good luck for the lung team. Great work. احنا عملنا اللي علينا، بس to tell you the truth I'm worried. انما that's the nature of the game يعني. وسيت ذا ديتس بقى وربنا يسهل ان شاء الله. جود لك. ثانك يو فيري ماتش يا جماعه. ان شاء الله تحتفلوا انتوا بقى بال 30 سنه و 25 سنه. طيب.